Hello everyone and welcome to Your Health, Your Choice. I am Dr. Roopnarine and we are coming to you live from our studios at ACTN. On tonight's program, we are going to be discussing cardiac health. With me in studio tonight is Dr. Mandreka Bahall. Dr. Bahall is a consultant cardiologist based out of his offices in Union Park East in Marabella. As usual tonight, our numbers should come up at the bottom of your screens, and we'll do our very best to get to each and every question during the program. So guys, let's talk about your heart, let's get the show going, and let's say hello to Dr. Mandreka Bahall. Doc, welcome to the program. Welcome to Your Health, Your Choice. It's a pleasure to have you tonight.
Thank you very much, Robert.
All right, so Dr. Bahall, you're a man that we kind of like work near each other, and we've been in contact a lot over the years with many patients that we've dealt with together as well. Cardiology is a massive topic, right? But heart disease and ischemic heart disease and heart attacks is something that I want the public to get a good idea about.
Right.
This is the basic, most important part of cardiology for our patients.
You know why?
Why?
Because heart disease or coronary artery disease, also known sometimes as ischemic heart disease, is the commonest cause of death in Trinidad and Tobago.
Exactly. So that's
32% of cardiovascular of deaths result because of cardiovascular disease. 32%. All the rest is 68%.
Okay. So we're going to go through it. We're going to explain some terms that the public might basically have an idea about, but might not be too clear on, like ischemic heart disease, myocardial infarction. And then we're just going to go through some of the risk factors, like what may cause this problem. And then basically we need to inform the public as what symptoms they may get or what is the signs of a heart attack that we may be having, and how they could go about treating it at home, and what's about to happen in the hospital. And then so after we take them through the treatment, we're going to give them some preventative tips, how to prevent themselves from getting cardiovascular disease or ischemic heart disease. So it's a packed show. And in between that, we're going to try and take some messages and calls from the patients at home. All right? So we're going to be pushing you quite hard.
Yes.
And we'll try and get through as much as possible. All right, Doc?
No problem.
So if you could just, to start us off, just give us a little explanation of these two terms that we hear all the time: ischemic heart disease and myocardial infarction.
Right.
What is that? And I know you have some slides and stuff that you brought. If you could take us through that first.
So, slide 2. Now, ischemic heart disease results when there's lack of blood or oxygenated blood going to the muscles of the heart, for whatever be the reason. The main reason that we have causing that lack of blood or oxygenated blood to the myocardium or the heart muscle is because of some blockage in the coronary artery. You put up that slide there, Josh. So the coronary artery, which is supposed to be nice and smooth,
so
starts to develop.
That's the slide there?
If you look at the top picture there, the artery is quite clear. But with time, it gets blocked because of plaque formation. And when this plaque reaches a critical level, less blood goes in, or it may occlude completely. And then the person may experience symptoms or whatever it is that make them develop a heart attack or damage to the muscle. That slide on your right, that black area is when the arteries is blocked. Causing muscle damage or a heart attack.
Because the blood isn't flowing and the oxygen isn't getting through.
The blood's not going there. Now, that plaque is developed for a number of reasons, but basically, once you have less blood, less oxygenated blood, there will be ischemia. When it's occluded or blocked completely, you get a heart attack.
So basically, the process of that narrowing off is called ischemic heart disease, or that's the process of it narrowing off?
The process of narrowing leads to the ischemia. And then the second picture shows where the blood no longer flows through that blockage is what the ischemic heart disease is the heart attack. The outcome of heart attack, myocardial infarction.
All right. So that's pretty clear, but what you showed us in those diagrams was being blocked off by plaque, right?
By plaque.
Now, that's cholesterol.
Cholesterol and other platelets and that adhere together. So can you
explain to the patients at home, because this is a topic, this is a word that they hear all day long: cholesterol, cholesterol, cholesterol. What is cholesterol?
Well, cholesterol really is a chemical which we need in the body, but when it's excessive, all of us need cholesterol to form cells, membranes, or certain endocrine things in the body.
Right.
But if it is excessive or bad cholesterol, it tends to form these fatty deposits in the lumen of the coronary and the arteries of the heart.
Right.
And these fatty deposits, with time, get bigger and bigger.
Yeah.
And there are a number of things which could catalyze that process, which we call the risk factors for coronary artery disease.
All right. So we will probably go into a little bit more cholesterol later on.
Right.
But it was just important just to explain to patients what that term means.
That's fatty deposits.
That is fatty deposits.
In the coronary artery.
So what are the risk factors for ischemic heart disease that we have here in Trinidad and Tobago?
Right. Now,
these are the factors that will contribute to this illness and eventually the heart attack.
Right. The risk factors are the same across the world, but there are some might be more predominant in our local setting.
Okay.
We have done a number of studies on heart disease, and number one heading the list is hypertension, diabetes, and of course the fatty food, or the cholesterol itself.
Right.
Other factors that we encountering, especially in this decade, is stress and depression.
Okay.
Then they have other things like lifestyle factors, just smoking, your alcohol, people who leading very sedentary lifestyles.
Right. Is race a risk factor for heart attacks in Trinidad?
Absolutely.
Okay.
There are a couple of factors which are non-modifiable.
Of course.
As we get older, there's a greater chance to get heart attack.
Yeah.
Your race, people believe that that ethnicity, Indo-Trinidad have a greater risk to develop heart attack.
Is that true?
That is true, but I have a feeling in Trinidad context, even that is true. There are much more, there are other factors which override that ethnicity. That ethnic part of it.
Okay.
Right? So therefore, I think we should pay more emphasis on what we could modify. So age, gender, family history, and so on. They are non-modifiable, but even though there may be some genetic link to heart attack, the other modifiable risk factors carry a greater weight. You're smoking and alcohol.
Is it that it carries a greater weight, or is that we have more control over it?
I think it carries a greater weight over here, and we also have a greater control over it.
All right. So because initially, in the older days, I mean, the older physicians, right? Family history was everything to them.
Yeah.
And I suspected that carried the weight, the most important contributing factor to disease.
It carried a major contribution.
So if you can just go through some of the risk factors again, like how could patients modify them? I mean, if you just list them back over clearly.
So like in the case of diabetes.
Right.
Diabetes has, with the abnormal glucose metabolism and so on, increase the chance of inflammation in the coronary artery.
Right.
So if you are diabetic, it pays then to make sure that your diabetes is proper control. And diabetic control doesn't mean only taking your tablets or your insulin.
Yeah.
It has a package of things to go with the diabetic control.
Yeah.
Which is the lifestyle, which is proper eating, avoiding sugary food, fatty food, exercising. That's a must.
Right.
Together with the actual medication to ensure it's not just about taking tablets and exercising alone. It's to see if you attain targets.
Exactly.
If you don't attain your target, well, I taken my medication. That may not make any sense.
So what you're trying to say there, Doc, and is a really important thing, is that when you're treating chronic conditions, it's not a passive process. This is an active internal audit and an active audit that you are getting the best results for you as an individual.
Correct. So we can't say we take away medicine and that's it.
No, you have to keep following up that you get the best results for you.
I know we have good tests as a marker to see if your diabetic state is well controlled. And once HbA1c, which is the average of the blood sugar for 2 to 3 months, is less than 7 or 6.5 beta fat. Together with your exercise and your diet, well, at least you have done your part. The rest is to go.
So, I mean, I just want to take a 2-second break before we push on, but the treatment of medical conditions, you have to keep, you gotta say your own medication. You have to say, like, look, if it is, we have to titrate it to get the best results. And if things not happening, it's not a passive process. That's why you have doctors. That's why you have professionals, because we need to get involved to up titrate, down titrate, add. There's so many options, and that is how medicine has progressed. That there's so many different options in terms of treatments and pills and tablets and stuff as well to help patients get the best results.
And at the end of the day, the patient must follow.
patient must follow.
You could talk until the throat get dry, but if the patient don't follow to ensure these targets are met, whether it be diabetes, high blood pressure, cholesterol, meet your targets.
And that's why in this show we always put forward, that's why we do the show, that the patient is the active participant in the care.
Yeah.
They're the one leading and coming to us, and we are guiding.
We are, yeah.
I sometimes reference it to an athlete and a coach.
Yeah.
They're the ones that doing it and getting there, and we are the ones just to streamline them and help them get where they have to get.
It is the patient responsibility.
Personal responsibility.
My sugar still high, what should I do?
Exactly, and we will help. We'll do what we can.
But don't just say and have a laid-back approach and leave it like that.
So do we have any slides with the risk factors laid out there?
We have some risk factors from the Trinidad context. We could look at those slides here.
If you could call which one it is? You don't remember. Josh, if you could put up this slide with the risk factors from Trinidad context, and while you're looking for that, we will continue on. All right, so so these are different risk factors you have people with diabetes,
high blood pressure, cholesterol. Again, you have to reach a target.
Right.
How you do it? By taking less fatty food and all these different things.
Cholesterol.
Right? Then you're smoking excessive alcohol.
Right. The next part is that you mentioned, right, which I think is very important for the people to hear. You said stress and
depression.
And depression, which I didn't expect you to say. Tell me about that.
That's a big thing in this decade. Right now, stress and depression, those things have an effect in the coronary artery. The inflammation itself, through this cascade of from the brain going back to the adrenal gland, going to the coronary artery, to increase inflammation right at that spot. Right. And once you increase inflammation in those arteries, the chances are it's going to get greater amount of plaque formation.
All right. So, Doc, like sometimes people say, we'll get to the slide just now. Sometimes people say a long time we used to say stress used to kill people, and maybe it's because of stress I get all these problems. And sometimes as doctors, we might say, well, stress is not really going to cause a physiological change, not really. But nowadays, we are saying, yes, you are right. Stress does cause actual physiological changes in your body and could cause you to get heart disease.
And it could cause changes in the cardiac muscle itself. But I'm not even talking about the muscle. Yeah. It could cause direct changes in the coronary artery and cause inflammation there. So therefore, if we have stress, better believe it's going to cause increased amount of blockage or plaque formation. And furthermore,
tell me,
when you have a heart attack, if you don't control your stress and depression, you get more angina.
Exactly.
It's a whole cycle. The stress causes the heart attack, and the heart attack making you get more stress. Unless you don't look after it, you end up getting more ischemia. And it's a whole cycle of affairs. So we need to stop the process. Stress and depression is big business.
Sorry, Josh. I just want to get up on the cross. Could you put back up the slide there, Josh? Thank you. It's a little difficult to see there. But it's the prevalence of clinical risk factors among patients.
Yeah, well, this was really when we looked at patients when they get a chest pain.
Yeah.
Right?
Yeah.
To see what kind of patients out in the open there.
Yeah. When you say we looked at, who do you mean we? Is this a local study?
It's a local study.
Okay. So where was this study done?
In San Fernando General.
All right. Tell us a little bit about this study.
We looked at...
Because the patients are interested to know what we do. Local studies are extremely important to our local patients.
Right. So when we look at patients who say they have chest pain, and we take them through from that point of getting the chest pain to what they actually did before coming to hospital.
Yeah.
And in that profile of patient, a lot of them have the diabetes and hypertension, and smoke. Some of them had a heart attack before. But when they got their chest pain, they didn't follow the guidelines.
Right.
If you look, when you get a chest pain, we always advise patients at that point.
We're talking about the guidelines of what to do when you get chest pain.
What to do when you get chest pain.
That's a very important question. I mean, it's not really the risk factors for it,
No, it's not really risk factors.
However, this is important information. What do the patients do when they get this chest pain? Right. So tell us.
So a lot of them, when they get the chest pain.
Yeah.
And they may present with other things as well, but by and large, the majority present with chest pain. When they get the chest pain, some of them ignore it. Some of them think it's a stomach pain. Some of them go and even though they feel it might be hard, they call a neighbor to take some kind of bush tea or some other things.
Right.
So many of them now have a long delay in actually seeking help.
All right.
Maybe when they get a chest pain, rather than taking a GTN tablet to put under the tongue just to have immediate relief, to open the artery, don't do it.
Yeah.
So because of that ignorance, because of the fear, because of a number of factors which one of the slides in this evening has it.
Right.
They do not seek attention. Right. And if you look at the time scale of how patients address this problem, Josh, you could put on the next slide with the time scale.
Yeah.
Within 5 minutes of chest pain, you're supposed to call for help.
Right.
And we find, next slide with it. 3.5 hours we wait.
The next slide, Josh, with the interval time graph.
3.5 hours before.
Right, that's fine.
They actually seek help.
Right, 3.5 hours.
3.5 hours, when it's supposed to be 5 minutes.
Okay.
So you find out, now, if they have a heart attack, now they have chest pain, which you don't know if it's heart attack or just angina. But time is muscle.
Time is muscle.
If you do not get into a proper institute early, you would not get the attention you need to address that problem.
All right, so I'm going to stop you there, Dr. Bahall, right? And before we go to that graph, are you saying that when you did the study in San Fernando General Hospital from the patients that got heart attacks, the one thing that stood out to you as a researcher was the length of time between chest pain and hospital presentation?
Correct.
Right. Now, in the world of medicine, in the world of cardiology, all over the world, we try to bring that time down to as minimal as possible. So in Trinidad, we still have a problem, people coming too late to the hospital.
And that is because of all the other reasons. Right. They're not educated enough to know, well, this could be heart attack.
Right. Now, let's answer that part of it so we could help this process. What are the symptoms of a heart attack that somebody would experience at home? Maybe some patients don't know or not sure. What is the symptoms? Can you tell us what are the symptoms of a heart attack? If a patient, so we're sitting down, a patient is sitting at home, they're watching the program, and they're getting a kind of chest discomfort. They're not sure if it's it might be gas, it might be a muscle pain. How are they to know that this is a cardiac pain, Dr. Bahall?
This also confused even we as physicians. So because patients with ischemia or heart pain, or having a heart problem at that point in time could present with chest pain, could present pain in the belly, could present in the shoulder, could present up in the neck, and it has presented in all different ways. And some people may present not even with pain, they may present with a short breath or sweating. Some people just feel the heart racing or with a mild discomfort. All these things they could present with. Most commonly is chest pain, which is pressing, squeezing, burning. Those are good symptoms, and the more you have of it, the more likely that this is a serious problem.
Right. So I'm going to break that down a little bit with a little bit more clarity, just for the viewers at home. So the typical cardiac chest pain is this.
Pressing.
The patient actually does this. They feel like if somebody's sitting on their chest.
Well, that's the extreme. But a lot of us may just
Let me go through the general, and then I'll give you somebody. And then sometimes they might feel pain coming down the hands, into the neck, and some shortness of breath. But that is the classical description. However, a large amount of patients do not fit the classical description, and that's what you want to explain to us now.
I had a patient in my office today, and he doing his stress, and he started to feel burning. And he had major changes on the ECG.
Right.
Just a burning, no chest pain, like how you talk about, no sweating, no upset feeling, no vomiting. Just that alone, something wrong. Now, mind you, if one suspect heart pain, there's no harm in putting a tablet under your tongue, GTN.
Right.
It opens up the artery.
Right.
Just, if it's not hard, it can't do no harm. Exactly. And if it's hard, it makes a big difference.
All right. So we have this patient, Josh, I'm going to take a break in just a little while. We have this patient at home. They're getting some chest discomfort running from the belly button to the neck. It might not be the classical symptoms I described. You are saying, hey guys, it could be any sort of chest pain, could be cardiac. So you are telling these patients, look, they're getting this pain, take a little GTN tablet if they have it at home, and put it under their tongue.
Right.
And then make their way.
Within 5 minutes, if they take 2 and the pain still there, must call for help. Ambulance.
Must call for help.
Because 5 minutes with 2 GTN.
Get your tail in the hospital. Get yourself in the hospital. All right. Any other recommendations for them to do at home? About aspirin?
Well, if you are accustomed with this problem before, there's no harm in taking the 4 aspirin and 4 clopidogrel or Plavix, we commonly call it. There's no harm. But if you're not, it was the first time, there are other things which could cause chest pain, from dissection, the pulmonary embolism, all these things, and the patient may not know.
Right.
And that is why those patients within 5 minutes call for help. So a physician could institute the appropriate treatment.
Right. So Dr. Bahall is saying you get this pain at home, you're not sure. It might, if you have a history and you know that it sounds like chest pain, take it to GTN, not settling down, get into hospital right away. Within 5 minutes, call the ambulance.
Yeah.
And you're saying if it's somebody who knew and they do suspect they have a chest pain, don't really do anything much other than take the GTN if you have it at home, but make your way to the hospital.
Make your way.
And there's no main necessity to take the aspirin. Is that what you're saying at home?
If you feel it is from cardiac,
take aspirin.
So you could take 4 aspirin and 4 Plavix.
4 aspirin and 4 Plavix.
If you're unsure that part, I would say leave for the physician who sees you, hopefully within that 30 minutes for transport, and as you reach in the emergency department, if you're in a proper emergency, you will be seen within 5 minutes of arrival.
Right. So I usually tell my patients, right, this is where we disagree a little bit. I say, if you're not sure, I mean, nobody really has Plavix at home in general public, right? I say take your 4 aspirin.
Yeah, but no problem with that.
Heart is muscle because
4 aspirin is better than 4 aspirin. It's still something.
Because you are saying 5 minutes get in the hospital, but this is Trinidad.
Yeah.
Sometimes they have no transport. Patients are calling ambulance to get in this. I mean, no offense to anybody, but the reality is people sometimes not 5 minutes away from a hospital.
Yeah. No, well, I
more
agree.
often than not.
It's just that sometimes if you never were diagnosed before and you have you're having chest pain,
it could be something.
It could be a dissection, and you don't want to miss out on that.
All right, so you get into the hospital. All right, guys. So we're going to take a little break. We're going to take a 1-minute break, and when we come back, we're going to move on a little bit more, talking about cardiac health and in Trinidad and Tobago at the moment. I'm here with Dr. Mandreker Bahall.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
Football 101 is on every Tuesday and Thursday night at 9 p.m.
I'm your host, Josh Rudy Matos, and I'm joined by Nikolai Madri, Jeremy Bridgenap, and David Lucky.
This is where you'll get all the football news that you need to know.
Glamorize football to what it is. This viewership speaks for itself at the end of the day. These guys are making billions on viewership.
With heated banter.
They'll have more trophies, more Premier League trophies, more
You are talking past. I'm talking about current situation of the club.
And trending discussions.
Barcelona was built around Messi.
Well, Messi created the most chances against Real Madrid in the Champions League.
Covering all the major leagues.
If you all don't win Europa, you can hold this. This is the only cup you all are going to hold.
Failure to support their core coaches with the kind of budget.
I think you have somebody delivering some food for you. We need to get service like this on the show.
Yeah, I can do some of that right now. It's about that time.
Football 101, bringing the field to your home.
You have the most assists right now.
All right, guys, welcome back. Your Health, Your Choice. I am Dr. Roopnarine, and I am here with Dr. Mandrika Bahal, and we're talking about heart disease or heart health. Doc, just before we broke there, right, we were talking about the different presentations of chest pain. You are a man that has seen everything, seen it all. Mm-hmm. And that's why, sometimes there's a saying in medicine, the more knowledge you have, the more hesitant you are. Because you see everything.
Yeah.
And you basically then give our patients at home some advice as to what to do to get into the hospital immediately, right?
Right.
the next step is what happens to the patient when they enter into the hospital? Because you're telling them, look, take some aspirin, take 4 aspirin, get into the hospital. When they get into the hospital, what should happen next? What should ideally happen next to a patient who is suffering with this chest pain? It's just for the public knowledge so that they could see what is happening.
Yes, yes.
And then we'll move on to some other discussion after
we treat patients with suspected ischemia very aggressively.
Right.
So when you arrive in the emergency department in the hospital, we would hope that you will be seen within 5 minutes.
Right.
And at that time, you could be triaged properly, do an ECG, and given some initial treatment. And that treatment, if you have not done so yet, with the aspirin and your Plavix, will be given to you at that time.
Okay.
The ECG is what decides whether you're going to get further treatment in the emergency room, like thrombolysis, a clot buster treatment.
Right.
If you have no kind of findings on your ECG, you were treated with the normal medication and observation on a continuous basis.
Right.
So after the emergency officer sees you, giving you your ECG and your aspirin and your Plavix, you are admitted to the ward. And in the admission to the ward, further treatment will comprise a number of medication plus advice as well.
Okay.
Right? Medication in terms of you get your usual blood thinners, your cholesterol tablet, you travel to control the blood, your pulse.
And the purpose of that medication is to do what exactly from that first diagram you showed us?
From that, when you have your artery on that plaque, we suspect it ruptured.
Right.
And when it ruptured, it leak of blood and blocking the artery.
Right.
So when we give you all these drugs, these aspirin and Plavix to wash it off, we also give you our next blood thinner called heparin. So everything is to kind of wash that clot from accumulating to cause full blockage.
All right, and allow more blood to
and then you have your cholesterol tablet to prevent that plaque from inflammation.
Right.
Then you have, because your heart rate tend to go up a little bit during this time, we will want to give you drugs to control the heart rate. And very important is the drug for pain.
Okay.
Your GTN or your infusion or your morphine or all the other drugs.
So that happens, we have the patient up in the hospital, and they get all these medications to make them, to open up that artery a little bit, and then they go home.
Medication and advice. Advice is a long list.
Exactly, yes. I hear you.
Advice is much more important than sometimes the pharmacological treatment.
What is the advice, Dr. Bahal?
Advice until if you have a heart attack.
Yes.
The advice could be cardiac rehabilitation, stop smoking, stop drinking alcohol in excessive amount, and trying to do go in a program of cardiac rehab.
Right, to minimize the risk factors as well as other things.
And control the risk factors.
Yes.
And of course, at that point, now, you asked me in a good hospital. In a good hospital, what we could also be doing is try to get your angiogram and your interventional surgery, if you need it, within 2 to 5 days.
Yeah.
In our setting, we may not always do it. We end up putting them on a list to have it done at an elective
But not
period.
all patients will need that.
Once you have a heart attack, you will need that.
Angiogram.
If you don't have a heart attack, and we are treated for suspected angina, we will be seeing you again soon after to clarify whether, in fact, your angina pain comes from an artery which is more or less 70% occluded or 50% occluded.
So this is the angiogram we're talking about.
And that we could be. So we could do tests to be able to determine how bad your arteries are. Stress testing, stress echocardiogram, or angiogram, as the case may be. If you have a confirmed heart attack, angiogram.
All right. So what other advice you said that was important that you say that patients need other than the risk factors and the cardiac?
Right. Is
it lifestyle advice?
Lifestyle advice, when to go back to work, when to go back to laboring work, when to go to a job, when to go to flying, when to go back to driving, sexual activity, all these things are part of the activities of daily living advice.
All right. So, Dr. Bahal, one of the big, I just want to move your way a little bit because we've taken the patient through. And you've given...
Most activities can be started back within 2 to 4 weeks.
4 weeks after
driving, flying, and all these things.
Right. So we've taken the patient sort of through. Now, in terms of prevention, right? This is a big thing in Trinidad that we need to understand. And people ask me all the time, what is a heart-healthy diet? We heard this term bandied about all the time. What is the appropriate diet for one to prevent heart disease? And what is the appropriate diet for somebody who has had a heart attack? Does their diet radically different? What is the most appropriate foods for this person to consume?
Well, show me the other side with the food plate.
Is that the one?
No,
There's that slide? That one?
Before that.
There's only 2 slides there, Dr. Bahall. Yeah.
Don't play that food. Yeah, so.
Oh, that one there?
Yes. No, that's.
Is this familiar?
That plate of food is what most of us eat.
Yeah.
At some point during the week. Not once in a month, you know.
Well, yeah, that glass
with your
as well.
fries and your fatty food and a lot of saturated fat, a lot of trans fat.
Yeah.
I know. You see, food is a big problem in Trinidad.
Food is a big problem in Trinidad.
Big problem, because we have so many fast food outlets in Trinidad.
Yeah.
So many
convenience food.
Convenience food that it kind of makes you, because of the taste, want to gravitate towards that. Like you can't escape it. So in doing so now, we end up causing problem for our artery. Yeah. So that kind of food, and I mean,
Josh,
saturated fats.
Saturated fats is the ones with the burgers and the hamburgers and
yes,
so on.
and you have the trans fat where you have deep frying and all these things.
Right.
I could list a few of these here.
List it out.
Let me just run it through. The trans fat is something which is the hydrogenated oil, right?
Yeah.
And simple things, like cakes and cookies and pies, microwave popcorn, I love that. That is bad business.
Yeah.
Frozen pizza, every day we're going for pizza, and right. Refrigerated dough, biscuits and rolls, all that things with fried foods.
Yeah.
Deep fry, because the oil can last for long, trans fat.
Right.
Donuts and fried chicken, coffee creamer, stick margarine. So all these are the trans fat food.
Right.
No, you don't want that.
No.
In fact, a lot of places in America ban trans fat food altogether.
Right.
Yeah, because of the problem with damaging your coronary artery and the plaque formation.
All right. Josh, if you guys put back up that slide with what the plate should look like, because I found this was very interesting, Dr. Bahall. I must say, I just glanced through when you and Josh were doing the slides.
I'll look at the saturated fat thing that we should cut down on significantly. Red meat, like beef, lamb, and pork, chicken skin. You could eat the chicken, but not the skin.
Yeah.
Whole fat dairy product, milk, cream, and cheese. We all eating that.
Right. So
butter, ice cream, lard. So our food here is really, really horrendous.
Yeah.
I don't know what we could do about that.
Right. I want to go back to that in a second. Put back up the slide there with the plate there, Josh, please.
The big plate there.
Right. So
the food.
That one I want to talk about. Okay. That is what is interesting to me. Now, that is very interesting to me, and I'll tell you why that is interesting to me. Because you say this is the ideal plate. This is what the ideal plate should look like, right?
In a simple way.
In a simple way. It should look like the majority of that looks like 1 1/4 of the plate is vegetables, fruits, whole grains, healthy fats and protein.
What I advise patients, this is the Mediterranean diet.
Right.
Half your plate
half your plate
is vegetable food.
Right. So that is why it's interesting to me, because that's not what we do here in Trinidad.
No, we eat vegetable at the very end.
What we get in Trinidad is this. And no, it is important for us. It's important for us to describe this, because maybe if we change the way we do things with food, we might have a healthier society.
Right.
So what we typically do at home in Trinidad, even at our house, not necessarily in KFC or the fast food outlets. Josh is making me aware we can't name places, right? In fast food outlets, what we do at home in our house is that we take out a plate of food. The majority of it is rice. Right, that's our Trinidadian culture. When you go to your house, anybody's house, you get rice. Then you get probably the next biggest component of that might be the meats, and then you get a little bit, and then you might get a slice of tomato and a lettuce leaf on top.
A 10 piece of cucumber, how you can see through it.
Right. So we
refuse to take it.
We might be thinking, as a society, we're eating healthy. We're not buying fast food. We're eating home cooked food. But we are actually causing harm to us because we have getting the proportions and the ratios wrong.
Right.
So what we should really be eating...
The heart-healthy diet comprises a plate with half of the plate.
Exactly.
To make it simple, vegetable food.
Exactly.
Not vegetarian, vegetable. Your cucumber, your lettuce, your cucumber, all these, your broccoli and all these things. The other quarter is your peas and beans. Right. And the last quarter, if you want to call it junk food, is your rice and your...
Right.
And even that you could be fine-tuned to a better form of rice or roti, as the case may be.
So you and I both have patients who say, look, well, I don't go out and buy no fried food. I don't really do this. I don't really do that. I don't go and eat a set of doubles. I don't go and eat whatever else. Hey, how you eat at home, and if you take on this piece of advice that we just show you there from that picture, you could actually switch around a lot of your risk of heart disease.
Correct.
And I think that message that you just push out there, vegetables, majority vegetables, that message is lost. People don't realize that because it's lost.
And we didn't say vegetarian.
No.
Vegetable.
Right. So,
and that's what we need.
And even vegetarian food could be somewhat unhealthy too, because people fool themselves as well thinking that they're vegetarian.
Exactly.
Because
what's up shot and rice and dal and parsad and all the other things that, I think
it's worth your while actually just telling people like how, because vegetarian food, especially in Trinidad, sometimes they prepare the vegetables in like a fried way and are oiled, and
that's the next thing.
It's not vegetarian. It's not healthy anymore.
We end up using a lot of trans fat food or oil in the preparation of these things.
To make it tasty, no?
To make it tasty.
Yeah. And it lose the benefits of the vegetables.
Plus, it lose the benefits, plus it adds the toxins in the body.
Exactly.
So therefore, we want to cut down on saturated fats, and we want to abolish as fast as possible trans fat, which is these things that could
let's repeat it again.
Deep frying. The manufactured form of trans fat, right?
Yeah.
Like your cakes and your cookies and pies.
Yeah.
Your microwave popcorn, your frozen pizza, biscuits and rolls and fried foods and all these.
So on that same picture that Josh has up there for us, right? In addition to that nice, and I'll leave it up there. In addition to that, I seen water there. How much water should the average Trinidadian probably doesn't drink enough water? We've discussed that.
2 liters of water.
We've discussed that in the show. 2 liters of water.
Yeah, 2 liters.
And I see you have alcohol there. Is that a positive or a negative? Well, a glass of wine?
It's supposed to be about a course on the alcohol, or unless you want to have one drink.
Positive. Huh?
One drink.
One drink.
An acceptable red wine or so.
Red wine.
But
rum?
Red wine
sounds very European, not very Trinidadian.
But in general, too much alcohol is not good.
No. And I think the rationale why red wine and so on is helpful is the flavonoids in the red wine, isn't it? The actual component in the grape skin is antioxidant or anti-inflammatory, and therefore that's why they say red wine is fine.
Now, we spoke about food, but another big problem in Trinidad is living a sedentary lifestyle. If people get a chance, they're coming right in my office and park inside the office, inside the waiting room. They wouldn't want to park anywhere and walk about a half minute. They prefer to come on. If I get them a chance, I open the big door and they go inside and drive in and they see me.
All right, let me ask you a question here, right? Is heart disease worse in Trinidad than in other countries? You said it's a big problem in Trinidad, and the first line out your mouth this afternoon when you started the program is it's a big problem in Trinidad. Is it bigger than in other countries?
Put up that slide with the Trinidad. Let's see if I find.
You're gonna have to give him a clarification on this slide.
The number 3.
And which folder it is?
Slide 3. 3 folder number 3.
Yeah, that's a graph.
Right. Now, the average premature death is less than 70 years of age. Our average, the next slide in the same one.
That's the slide you want there?
Yeah.
All right. Could you
the next one.
That?
Right, okay.
Can you explain that to us?
I'm going to explain that.
Yeah.
So, our age in Trinidad is 59 years.
Right.
Abroad,
what is 59?
the mean age of getting a heart attack is about 59 years.
Okay.
Abroad is in the 70s.
Okay.
10 years later.
Okay. So we get heart attacks earlier.
About a decade earlier.
Right. That's the point you want to make.
That's the point I want to make.
Right.
So therefore, we're not doing something right, and that's because of our cardiovascular risk, which is much higher in many areas than abroad.
All right.
Now, that graph tells you on our population. If you look at the middle one, you see the blue?
Yeah.
Out of 150 per 100,000 is the Indo-Trinidadian male.
Yeah.
And sitting next to him is that orange color, the Indo-Trinidadian female.
Right.
Very high, close to 100 as well, 100,000. And on the left-hand side, your Afro male
Trinidadian.
And the Afro female is the lowest, around 40 per 100,000.
Right.
So the Indo-Trinidadian has the highest risk, and I don't want to blame gene for that.
Right. You don't want to blame
I don't want to blame genetics for that. It is because of our lifestyle.
Right.
And that is mainly because something is not clicking right with our population, where the food we're eating more trans fat or more saturated fat, whether it's because of sedentary lifestyle, in combination with all the other risks, which may be increased as a result of the lifestyle type problems.
All right, Josh, some little feedback there. Now that we're talking, right, about the lifestyle, now, the Trinidadians, I think, I'm trying to get exercise more. I mean, you see people outside in the parks. I mean, there was a big clamor to get outside during COVID. Right. Let's just exercise. We want to go and swim. We want to go and run. We want to go and walk. What is the best exercise to help people prevent cardiovascular events? Is all exercise created equal? Is there better exercise? What is the recommendation amount of exercise that someone should get to be heart healthy?
The dynamic exercise, one that allows the heart rate to speed up. That's what we need. Whether it could be walking or jogging or running up the steps, once we get the heart rate to pump up, that's the exercise we need. The guidelines say that you need that to exercise at least 5 times a week, about 20 to 30 minutes per day. Right. Not walking around the savannah and playing with your dog and talking to your neighbor and all these things, or going up to cook. And that is not exercise.
No, that is
lineman. That is lineman. People say, I make 12 laps, but they're just taking the time. You want the exercise to rev up your heart rate, get the speed, and that's why a lot of people come to do stress tests to see how much they could endure without going above the limits for their heart rate, for their particular cardiovascular state. But at the end of the day, you want your heart rate to race off, so you could see the effect to see whether you have any pain or whatever it may be.
And what exercise would you recommend to our viewers at home that might be the most appropriate to get that in a time-efficient way in a busy world?
Well, you could be in your yard running up and down the place. You could be going up your step, jog up and down the steps. You could be in your, but rushing at least to get the heart rate up. If you're close to a gym, you could go in a treadmill. Different form, but once your heart rate goes up.
So Doc,
to do nothing or sedentary is really, really bad business.
That's an independent risk factor for heart disease, isn't it?
Independent risk factor, sedentary lifestyle is an independent risk factor.
And we all get
together with stress and depression, where you need to get counseling and proper stop quarreling with people and be more calm and doing yoga class and all these different things.
So Doc, let's get some feedback from the audience at home, all right?
Yeah.
So Josh, you could put up the questions, please. How long can one live with 40% efficiency heart rate?
The ejection fraction of 40%.
I think that's what the viewer meant.
I've seen people with 10% living for 5 to 10 years,
so
no problem.
What the viewer is asking is really ejection fraction, which is 40%, which is how the heart pumps and ejects. Because we're doing this for the other viewers who might not understand quickly.
So that ejection fraction normally is around 60-65%.
Right.
And whoever it may be is around 40%. So I'm saying I've seen people with 10% ejection fraction that's moving like this.
Live
5-10 years, no problem. But I mean, you could have problems at some point, heart failure, or you could get arrhythmias. But
so it's not that, I mean, to that viewer, basically saying what the proper medical treatment, you're not asking a question that the doctor cannot say how long you will live, because with proper medical treatment, you will live.
You will live, yeah. And we can show the last slide too. S5, right?
All right, well, if you can get it, we'll put up the next question there, Josh. Let's get your feedback from your viewers. Is there a substitute for aspirin when you're allergic to it? Very good question, viewer.
Aspirin is a blood thinner. We could use clopidogrel.
Okay.
And in fact, my mother-in-law, she
allergic to aspirin,
and she used clopidogrel, and she's fine.
Okay. So there's a drug called clopidogrel,
which is like Plavix or Antipla, but that's the chemical name clopidogrel.
All right. Josh, next question. I think you have 2 more, do you? What can someone do or take to improve their arteries, including foods? Well, I think you went through the foods. Is there any other kind of supplementation that you may be able to take? Any tablets? We always hear about omegas and we hear about zinc and magnesium and stuff. What's your opinion on that?
Once you have confirmed coronary artery disease, the 2 best drugs for life is a blood thinner like aspirin, which is cheap, 5 cents for one, and a cholesterol tablet, any statin, whether it be your simvastatin, those 2 main drugs. The rest, whether the omega-369 or the fish oil, no harm in taking that. People feel they want that extra support. Even though you do a 1% benefit, I have no problem. But the cost effectiveness may not be at what people promoted to be.
I hear you.
But the two important ones that have big benefits is your blood thinner aspirin or your clopidogrel, and sometimes your own doctor might prescribe 2 blood thinners depending on how if you're having angina ongoing or you had a recent heart attack.
All right. Any more questions there, Josh? How does my family history affect my heart health?
Well, certainly if you have a family history of heart disease, there's some genetic component and it could cause your own...
but I think you're right. But the acknowledgement that your future is your destiny is in your hands. It's important for the patients. Patients can hang their head and say it's my family, and that you have the control over you.
Correct. 19-something% of the contribution is from your own doing.
Yeah.
And I want to say own doing gathering because I have a slide at the very end in S5.
Just now.
Yeah.
I just want to. Any more questions there, Josh? Does being pregnant increase my risk of developing heart disease? Doc?
Not really. No, not really.
No. That's
post-menopause, menopause, they have a greater chance of getting heart disease because of the fall of the estrogen hormone.
Exactly. All right. So, Doc, you're pretty keen to bring up a slide there. What slide was that?
In slide 5.
Let's take your time. And what is this slide?
It's already graph with time now. All right, okay.
That one.
Keep that one right there. I want to show the audience something here.
Yeah, go ahead.
Now, at the bottom of that graph, I want you all to note very carefully. We always believe that the individual has the power.
Yes.
So, hey, you're obese. You're not eating properly. Go and eat properly now. Go and exercise. Go and do this. They're putting a lot of responsibility on the individual. But here's my problem with that, and that's behavioral changes.
Right. So what does this slide show us there?
The bottom part showing that the environment have a key role to play in determining what I eat, how I exercise, who I align with, what kind of stress I'm going to have. So in other words, the responsibility for heart disease is more of a public health rather than a primary care individual-like type approach to behavioral change. Watch what you eat, how you exercise. But I am saying to you, if there's no parks for me, if all the roads are...
That I get your point, Doc, when you're saying it clearly, and that's a brilliant point. And it's a point that even in America, they were pushing a lot as well. What you are saying, that it is not really only an individual responsibility. It is a public health responsibility.
You can't tell us...
Because you're putting too much unfair pressure on an individual when he has very little control of his environment.
Correct.
And that, for example, in a lockdown, a man couldn't go outside and run. For example, in America, they say inner cities are now become food deserts. They have no available fresh food in certain towns and certain cities.
No, you're correct.
In America. Is that the point that you're
That's
trying
the
to
point.
make?
So you can't tell me go and exercise, and all the roads you have parked cars on the road. I can't even walk properly.
No green spaces.
No green spaces. No, my personal space is lost because we take the pavement to park the car.
Yeah, all the green spaces are taken up by private contractors to put up houses, and people in the cities have no places to go and walk.
Then no park. And the same with food. You can't be showing me only convenient food and all these fast food things, junk food, and expect me to go and eat natural stuff.
And not only that, but it comes up a position of economics as well, because a lot of the junk food is positioned at a price point that the average man with a very limited budget and still see his kids and his family eat.
They're playing in mind. When you go in your supermarket, at the very last point of leaving, you're seeing chocolate, you're seeing Cheerio, you're seeing all these snacks, and you kind of crave for it because they play in your mind.
Yeah.
So here's where the public health model comes in.
So you can put back up this slide there again,
That
Josh.
lower area here looks at the public health.
Yeah, sorry to interrupt, and you could go on there.
If you're in the sea, and you're a top swimmer, but a tsunami comes, you can't get through. And we are facing the same problem in our society. When the public health environment is not conducive, I call it atherogenic.
Yeah.
How could you eat properly? How could you exercise? How could you do all these things without stress?
Yeah.
So these three major lifestyle issues are being destroyed because of our public health model. And who's responsible? Not me and you.
No.
It is the government policy.
Yeah. Infrastructure, because traffic could contribute to heart disease, because people stuck in traffic all day long.
Of course.
They might be getting hungry. They might be taking 2 hours to get home. They buy something fast for their family because they have to see their children eat, and then they might be too tired, too late in the night to exercise. So things like that, is that what you're trying to put forward to the public?
For the psychosocial, there's no peace in the society.
There's no peace.
The stress level is too high, from suicide to traffic jam to your family problem, no money.
And that contributes to heart disease?
Yeah, of course. And now with the pandemic, and now with the war and shortages, and so we're going to have more psychosocial issues. We're already hearing about the mental health issues that are being increased in the country. You could imagine how this is going to increase again later on because of that single factor, psychosocial issues.
All right. So let's take the question there, Josh, please. How can you differentiate between a heart attack and a panic attack? Doc, if you could just give our viewers some brief guidance there.
That's always a challenge because a lot of patients come in with the same chest pain and shoulder and tightness. We have to run tests to be able to clarify that. We have to treat them sometimes. Sometimes the personality and the history will give us some clues, but by and large, we may have to run some tests to clarify whether they have a heart attack or not by doing the ECG or the troponin levels. And once that's normal, you do a stress and you do it once or twice, and it's always normal. We could say that, look, this person, when they come back again, it's most likely anxiety attack. However, we don't want to put full proof on that. I've seen men who are alcoholic, came in with alcoholic gastritis, alcoholic esophagitis, and the third time, it's a massive heart attack, and you go on to say it's alcoholic gastritis again. So you have to keep your eyes wide open.
As a professional.
Because even with alcoholic gastritis, once tried the third time, it's a different problem altogether.
Wow. The next question there, Josh. What is a good diet for a seizure patient? Somebody with epilepsy. That's a hard question.
That's not my area, but I mean, I don't think there's any special diet for seizure. I mean, I try to avoid getting low blood sugars. I try to avoid seeing flashing lights. But in terms of food itself, there are some food I think could precipitate migraine. Certain chocolate products and so on. But seizures are not quite sure.
So that's fine. Any more questions there, Josh? All right. So, Doc, another little question. Another little question that I wanted to ask you there. I know you have loads of information and that you wanted to get out there to the public, but what is myocarditis? The public have been hearing about myocarditis during the pandemic, right? They're like, the vaccine might be giving people myocarditis. COVID itself gives people myocarditis. I think I might have had myocarditis. People use the term, but do people know what the term is? So can you just briefly define it so viewers at home will feel comfortable knowing what a myocarditis is?
In the heart itself, the heart is comprised of this muscle body. And that muscle body could be damaged from, we said before, from a coronary artery blockage and the muscle die. But sometimes the coronary artery is normal, but you get some virus, like the COVID-19 virus, that attack the muscle directly. And cause inflammation of the myocardium. Myocardium is a muscle, and that myocardium gives you called myocarditis, inflammation of the muscle. And that is serious as well, because sometimes when you get inflammation of the myocardium, of course the arteries are normal because it doesn't pass through the part of blocking artery. It damages the muscle to such a point that it could weaken it to a heart from a 65% to a 40% to a 30%. And you can get major heart failure as a result of the inflammation.
Doc, you know, sometimes in Trinidad we have this culture, the patients have this culture that they go and sweat out a illness, right? Where they go and they have a flu and they go and run or they go and play football to sweat it out. What do you have to say about that?
I think that could be dangerous. I think
it is dangerous.
I mean, the best thing to do is to rest and take appropriate medicine for supportive care. If it's a virus, some viruses may have a specific treatment, but by and large, you want to rest it and take the appropriate medicine for. If you have fever, you take your paracetamol. If you have
So the point I'm trying to get at, Doc, as well, is sometimes after somebody gets a viral illness, it's important not to go back to exercise immediately. Sometimes they should wait 2 or 3 days because there is a condition called myocarditis. And it could happen from a regular viral illness.
But once you have once you find your heart rate is a little more than usual and you're feeling down or exhausted, you have to check.
I usually recommend patients take 3 or 4 days after viral illness, after they feel better, before they go back to exercise.
And if there's a problem, you may need to see a doctor again to get appropriate evaluation for your heart.
Go ahead, Josh. You can put it on. Would you recommend cooking with coconut oil instead? Good question. It's a cultural question, topical to Trinidad. Doc?
I mean, I'm not too sure how much saturated fat coconut oil have. But If you
it's a big
check it
debate,
up, if it doesn't have much saturated fat, I say fine, you could go ahead with it.
Yeah.
I mean, the margarine and all these other trans fat type preparations.
What is the healthiest oil to cook with? Is it still olive oil?
Olive oil. That's what I read recently again.
Okay.
Reinforced olive oil has more unsaturated things, which can easily be utilized in the body and not cause harm in the coronary artery.
All right. So we're not too sure about coconut oil. Like in my days when I was in medical school and I read the book, they said don't use coconut oil. It's high in saturated fats. And that information has changed.
Yeah.
And a lot of other
like avocado. I just read recently where avocado is good.
Yeah.
They have the good kind of fat.
Exactly.
So eat plenty of avocado.
Josh, you could go ahead again. Is there any benefit to taking CoQ10 when taking statins? Good question.
No problem whatsoever. In fact, there is an extra benefit.
What is CoQ10, Doc?
It's one of those...
it's a supplement?
Supplement to use.
And what does...
anti-inflammatory properties as well. That's the main thing, anti-inflammatory, which is what we want. The statin gives a lot of anti-inflammatory properties because that plaque, it can be soft to hard, and when you have the anti-inflammatory properties, it prevents that plaque from breaking open to cause full blockage.
All right, so you can go ahead and take it with your statins as well, right?
No problem whatsoever.
All right. Last question, Doc, before we wrap it up, right?
We only show the last slide, eh?
You want to show the last slide?
The one with the... Show the last slide with the graph, with the post-heart attack.
Okay, yeah. Let me just ask you quickly. Statins, patients are worried about safety. It's safe, isn't it?
Very safe. The two major complications is the destruction of muscle because of the statin or liver impairment, which is extremely rare, 1 in 1,000 or 1 in 10,000 sometimes. So by and large, you can say it's extremely safe. And we can pick it up easy. I want to stop the statin, you're back to normal.
Hi, Josh, are we doing there? Yeah.
Next slide after that. Yeah. One below. Yes. No, we all believe that when you get a heart attack, that's it for you.
Okay.
But this slide demonstrates, we did a study of roughly 900 patients following the heart attack in San Fernando, Gerald. Patients who had a heart attack.
Yeah, go ahead, Doc.
And when they get a heart attack, now we'll follow them up for different times. For a couple of years to see their quality of life.
Yes.
When you reach hospital, at least you have reached hospital.
Yeah.
And when you reach there now, we have found that the quality of life overall improve over time.
Yes.
Many of them said they even, look, you see the graph going up, that means the quality of life in all domains, emotional, mental, and physical
domains. This is after the heart attack.
After the heart attack.
The quality of life improved after the heart attack.
And that's the graph there.
And that's the graph there. When you interviewed all these 900 patients in San Fernando.
I showed that it improved over time. And that study was stopped 2 years after.
Right.
So it means, therefore, or 3 years after, I think. It means, therefore, that there's hope.
There's hope.
And we should not feel because we got, oh boy, I walk slower, I should not go here, not go there. We encourage people to still eat as you wish within healthy guidelines. Your Mediterranean diet, exercise, meet your friend. Of course, you have to stop smoking. And this is what makes the difference. And that is patients who never got the help. From a formal cardiac rehab class.
So what you're saying is that like there was a silver lining in every cloud, that even though they went through this major problem, this is Trinidadian patients, or they went through a heart attack because of the interventions and the wising up and the eating properly and the exercising and the doctors and the greater care, that the whole quality of life improved.
Even better than how it was before. So it was a good thing to get a heart attack sometimes.
Well,
of course, we don't want that.
As we say. Doc, that's an excellent way.
We had an attack about both ends. Preventative public health, let the government deal with the environment, you deal with your lifestyle, and we have hopes at the end of the tunnel.
Right, exactly. So that's a good way on hope to wrap up the program tonight. All right, the hour flew by. I'd just like to thank you for everything. I mean, it was, you brought a lot of enthusiasm to the topic tonight. I know you had a lot of really full of messages and information that you wanted to get to the public, and I think we did a good job tonight. I think we pushed through a lot of information. I'd like to thank you for that.
Yeah, no problem.
I'd like to thank you for coming on to the show. I'd like to thank you for always being someone that the patients could turn to and always willing to help and always willing to share advice to each and every one. All right, Doc? So thanks a lot for that.
Yeah.
All right, guys. So we just want to wrap it up. It was a good program tonight. Thanks again to Dr. Bahall. Thanks to each and every one of you for tuning in tonight. Thanks to all of you who sent in some wonderful questions. And thanks to Josh for producing this show tonight. And we'll see you again next week. Have a pleasant evening, everyone. God bless. Take care. We'll see you again next week. Good night, everyone.